Ischemia refers to the imbalance between supply and demand in the myocardium. It should be differentiated from hypoxia, which is a insufficiency of oxygen. Ischemia, by comparison, is not only a decrease in oxygen, it's also a decrease in nutrients and an inability to clear all the metabolic wastes. Tissues are generally more tolerant of hypoxia than ischemia because it doesn't carry all those other elements. Coronary artery disease is really a disease referring to atherosclerosis. And we should really think of two patterns of atherosclerosis. The first is when we form a stable plaque. And a stable plaque has the characteristics of a thick, fibrous capsule, very little inflammation, and no necrosis. This means that it only becomes significant when it has occlusion. When it gets to 70% occlusion, that gives a demand ischemia, meaning pain occurs when the heart is very active. And that should be compared to 90%, which is ischemia at rest. And that's very different than when we talk about an unstable plaque. Because when we have an unstable plaque, it really doesn't matter how big it is. It has a thin capsule, abundant inflammation, so there are numerous inflammatory cells all through that plaque, and there's evidence of that inflammatory damage because there is necrosis. So there are large areas in which there's simply dead material, the so-called grumous tissue of atherosclerosis. This matters because it gives us a different pattern of disease. Stable plaques correlate with stable angina. It's a very predictable pain. That's completely different than when we talk about unstable plaques, because two things can happen in unstable plaques. The first is one can get hemorrhage into the plaque, causing occlusion. But the commoner pattern is when that thin fibrous capsule tears or cracks, and that then allows platelets to start aggregating and form the soft clot, followed by the factors that then form a thrombosis. And that thrombosis is the hallmark of unstable plaques. When we talk about unstable plaques, we start with a discussion of plaque rupture leading to thrombosis. But another critical element is that there is abnormal, dysfunctional endothelium. The endothelium has two critical functions in the coronary artery. The first is it's a major regulator of tone, in which it causes vasodilation through substances like nitric oxide and prostaglandins, and it causes vasoconstriction through substances like endothelin. So normally, anytime there's an increase in sympathetic, the second way we regulate the coronary arteries is neurally. When we have our norepinephrine causing vasoconstriction, that's in absolute balance in the coronary artery with the local endothelium, which is going to cause dilation. So there's a balance going on at this time. But if we have a dysfunctional endothelium, then that sympathetic stimulation is going to go unbalanced, and we get associated vasoconstriction. At the same time, we're occluding with a thrombus. When we put this as a visual concept of what happens in the heart, here's a full thickness portion of our left ventricle, and this is the inner chamber of the heart here. Then remember that our coronary artery is subepithelial. When we get complete occlusion of that artery, then all of the smaller arteries down below also get occluded. But this doesn't occur at the same rate for each segment, because remember that the heart only perfuses in diastole. So the heart furthest away from the artery and having the least amount of diastole is the inner portion of the heart, which is subendocardial. So subendocardial tissue starts dying in 1 to 2 hours, but it's going to take a full 3 to 4 hours before we get full thickness necrosis and a transmural infarct. And this is then going to correlate to two profoundly different EKG pictures that we're going to see. With subendocardial infarction, we see ST depression, but when we have transmural, we see ST elevation. And this then is going to present with angina, typically ascribed to a buildup of adenosine and other local products when ATP doesn't get built and adenosine is the result. And we're therefore going to see two patterns of angina. If it's from a stable plaque, then it's going to be a highly predictable pain that's going to occur based on the amount of demand. And that really can be based on the two measurable parameters we have for demand, which is going to be heart rate times blood pressure. So the double product will predict when the patient's going to have pain. It comes on with exercise and it leaves with rest. That's very different than when we have an unstable plaque. We have thrombosis and dysfunctional endothelium, and so we're running the whole spectrum now from ischemia through to subendocardial necrosis, all the way through to transmural. And because at the time the patient presents with chest pain unrelated to exercise and rest, all of these unstable plaque, the three basic syndromes, are lumped under the common heading of acute coronary syndrome. Acute coronary syndrome then has three possibilities. It can present with an unstable angina, meaning angina not related to exercise or relief by rest. Subendocardial, or by EKG, a non-ST elevation myocardial infarct. Or it can be transmural and have an ST elevation myocardial infarct, often referred to as STEMI. As we compare these three possible patterns of the unstable plaque, we can make a nice table to allow us to visualize each of them differently. If we take a look at the coronary artery occlusion, then the unstable angina will be a partial occlusion. Similarly, the subendocardial will also be a partial occlusion. But ST elevation transmurals, that's a complete occlusion. When we talk about which part of the left ventricular wall is involved in unstable angina, that is subendocardial. Similarly, in non-STEMI, that's going to be subendocardial, but in ST elevation, it is transmural. When we talk about necrosis, unstable angina is none, it is ischemia only. Non-ST elevation has some necrosis, and ST elevation is transmural, so it has much more necrosis. When we compare the EKG, remember that the unstable angina is only subendocardial, so we will see ST depression. Similarly, non-STEMI also has subendocardial ischemia, so it too will have ST depression. But once it's transmural, we see ST elevation of the transmural infarct. Unstable angina is ischemia only, so there is no troponin. The subendocardial myocardial infarct, by definition, has necrosis, and therefore there is an elevation of troponins, and the transmural will obviously have much more. So then this is how we think of and define the acute coronary syndromes, and we can appreciate the two things that we're going to need in clinical medicine to identify these patients that present with this crushing chest pain, not relieved by rest, not brought on by exercise. Our basic parameters of study are going to be our EKG and our cardiac troponins. I just want to stop and take a moment here to note that we've talked about stable plaques and stable angina and unstable plaques and acute coronary syndrome. There is this much odder phenomenon, which is our vasospastic angina. And this has had many names in the past. It goes by the name of Prinzmetal angina. But what is distinctive about it is that it is non-atherosclerotic. And so these patients will present with true angina, and that angina is often due to ischemia due to the vasospasm of the coronary artery, so you see variable ST changes, but it can include full ST elevation, and it has a normal coronary angiogram. This is thought to be an increased sensitivity to the sympathetic system, and that's why it's associated with such triggers as intense emotion and drugs such as cocaine. But in general, you're going to have a patient come in with chest pain unrelated to rest and exercise. You're going to work that up as acute coronary syndrome. When troponins are negative and the EKG resolves and you eventually go to angiogram and it's negative, then you can start thinking about your vasospastic or Prinzmetal's non-atherosclerotic angina. What is the typical presentation of an acute coronary syndrome? First of all, when we talk about the symptoms of the angina, compared to a stable angina, they have greater intensity, greater duration, and they are unrelated to exercise and rest. This then falls under the differential diagnosis of chest pain, which includes chest wall, pleura, pericardium, esophagus, and aorta. The physical exam basically is not typically helpful, and therefore we count on lab tests. The key critical lab test is going to be the electrocardiogram. The electrocardiogram is going to have two basic patterns that one is going to look at. The first is ST depression, and that will be seen in both unstable angina and a non-STEMI pattern of ischemia. And the second is ST elevation, which we will see therefore in a STEMI, ST elevation myocardial infarction, and that will be transmural. We can typically identify which artery is involved by the leads that are involved. This is a short axis view of the heart with our left anterior descending, left circumflex, and right artery. Left anterior descending is going to involve the leads near it, V1-2 in the anterior wall, and our V2-3 in the anterior septum, and in the right coronary artery, 2, 3, and AVF. At the medical school level, we don't typically talk about the left circumflex. Half the time it doesn't show a characteristic pattern, and then that pattern wanders a lot. So for simplicity's sake, most of the time we're going to stick to LAD and right coronary arteries. The other thing to remember when we talk about the EKG is that it evolves over time. We're initially going to start with ST elevation, but over 2 to 3 days, we're going to see the evolution of Q waves, which are the hallmarks of myocardial infarction. So ST elevation for ischemia, but the Q waves are the marker of evolving infarct. The second critical markers are going to be troponins, which are specific to the heart, so they're called C troponins, and they are released with necrosis and get to the circulation through the lymphatic system. If we take a look at the release of troponins, starting at time 0 of the myocardial infarct, they typically aren't found by conventional troponin levels for about 4 hours. We're starting to see high sensitivity troponins, and they're showing up in 1 hour, but that's a discussion beyond our present medical school understanding. And then having risen up over our 3 to 4 hours, they're going to then taper over 7 days. Now, over the past few years, troponins have released creatine kinase subtype MB. And the story behind that is they also take the 3 to 4 hours to raise, but they typically clear by 3 days. So if you're working with an older physician who hasn't yet completely converted over, you can appreciate that new onset chest pain in the 3 to 7 day period, you can use the fact that MBs should have cleared by 3 days to rule out reinfarction. Contemporary cardiologists don't do that. They simply remeasure the troponins, which will go up in myocardial infarction, and if they go up more than 20%, that would be diagnostic. So there's an older legacy test, CKMBs, but nowadays mostly people are just using the cardiac troponins. Myocardial infarction is used as the model disease for coagulative necrosis. It's very important that you master this discussion of the necrosis because almost every reference that we do to necrosis is going to use this as its model disease. And you notice we have to correlate the gross, that's what you see with the naked eye, with the microscopic, what you see with the microscope. And it's actually worth doing clinically because it really correlates very well with the complications you're going to see in the natural history of the infarct. First day, you don't see anything grossly. Now, microscopically, you'll hear pathologists talk about seeing wavy fibers. Yeah, well, I did hundreds of forensic autopsies. I could never see them. It probably represents the early edema following necrosis. But the complications that we see in day one are profoundly important. The first and by far and away the most dangerous are ventricular arrhythmias. These are thought to be reentrant patterns of arrhythmias, and 3% of your patients having a myocardial infarct will die before they get to hospital. So your first concern when a patient presents with crushing chest pain of acute coronary syndrome is take a sublingual aspirin for the platelets to prevent thrombus propagation and get them as fast as you can to a defibrillator because of this very high risk of ventricular fibrillation over the first day. The second great complication is cardiogenic shock. If you infarct more than 40% of your heart, you simply lack pumping capacity and blood pressure will drop below 90. By day 3, you can start to see the first of the color changes in the affected heart, and they start to turn a light tan. When we look microscopically, this is when we see our peak neutrophils. And when we talk about complications now, here we're talking about the first week or two, we're talking about two critical abnormalities. The first is that we've lost the physical integrity of the muscle without having to put in strengthening connective tissue. So the first we can have is a mechanical necrosis, and that's going to give us either a rupture of the wall or a rupture of the papillary muscle. The second problem that we have if it's a transmural is necrotic tissue is a pathogen-associated molecular pattern, and the PAMP can give us peak neutrophil infiltration. We can present with an acute pericarditis. This in and of itself is not life-threatening, but it does raise the possibility and differential of reinfarction. By day 7-10, one can clearly see the necrosis. The wall is soft and clearly quite abnormal. And also by this time you can start to see the red rim around the outside as we start to get new vessels growing in, so you can see the granulation tissue. If one's going to look microscopically, one can see the beginning of the macrophages. This is a classic time for macrophages to come, day 7-10, and we can start to see the new vessels brought in by the ischemia and VEGF creating angiogenesis. And then for several weeks, up to about 8 weeks, we start to see the gross formation of the scar. And like all scars, it's going to start with a type 3 collagen and over time become the much harder, denser, stronger type 1 collagen. If we look microscopically, we can see the fibrosis. And when we talk about the complications that we see, first is what happens if we have abnormal fibrosis? We can develop an aneurysm. And we think about an aneurysm is going to look like, if we took a look at our heart on side, it would look like this. And if we form an aneurysm, it's going to look like this. So the heart, instead of pumping the blood all out this way, is going to have some blood this way and some blood go this way. So the formation of a significant aneurysm is going to give you congestive heart failure. The second complication that occurs in this late period is a late autoimmune pericarditis called Dressler syndrome. And it's quite rare now that we have such effective treatments of STEMIs, but back in the day it was pretty common. Obviously, if we affect lots and lots of the heart, we can just get gradual heart failure, and the patient can have dyspnea of congestive heart failure. And then the last great risk of myocardial infarction is the dyskinetic wall gives you a non-moving wall, and it's a very good time to develop a mural thrombus that can flip into an embolus causing stroke or small bowel infarction. This is a critical table. Anytime you get into general path, this is going to be our model of coagulative necrosis, and it's always going to be compared to what happens in stroke, which is our model for liquefactive necrosis. So this is something you just have to put in your mind, and the key things you're going to see is peak neutrophils day 3, macrophages granulation tissue day 7-10, and then scarring takes several weeks. Let's finish up with a discussion of treatment. And we can see there's going to be two families of diseases we have to treat. Unstable angina and non-STEMI because they tend to have about the same prognosis. And what you're going to do for them is you're going to risk stratify. And there are tables for this. You can look them up and you can punch the numbers in. But this is going to include things like in the TIMI system, the patient's age, older's worse like everything, risk for atherosclerosis. So if they're diabetic, hypertensive, dyslipidemic, and sedentary, that's going to punch the ticket for a high risk. If they've had past history of atherosclerosis elsewhere in the heart, that's a risk factor. We're going to take a look at the EKG. Arrhythmias or other problems are higher risk. And the last is we're going to look at the troponin levels, because the higher the troponin levels are, that correlates with more muscle necrosis. If the patient is high risk, then you're going to treat them just like they've had a STEMI, and so you're typically going to go for invasive procedures. If they're low risk, you're going to manage them pharmacologically, and that's going to include things like beta blockers and antiplatelets ×2 and heparin ×1, and then a whole group of secondary drugs which will include your ACE inhibitors and your spironolactones. But the big group, and always the group that we worry about the most, is ST elevation myocardial infarction, because time is muscle. The definition of a cardiac center is time from patient presentation to angioplasty is less than 1 hour. And after 3 hours, there's really no point in doing anything. First, everybody gets put on aspirin because that prevents thrombosis propagation. It doesn't actually treat the obstruction, but at least it doesn't get any bigger. After that, you've got to open up the clot. If you're in a center with angioplasty, that's absolutely preferred. But if you don't have angioplasty, then you're really going to be going for a plasmin activator clot buster, because that's certainly better than nothing. There's going to be 2 platelet drugs. So after aspirin, the second one is typically going to be an anti-P2Y12, such as clopidogrel. As well, you're going to use heparin to prevent factor clotting. And then we're going to go to the adjunctive drugs, all of which have been shown to help, which are going to include our ACE inhibitors, statins for reasons that go beyond lipid management, and beta blockers for the sympathetic stimulation. And generally speaking, for the pain, one is going to be using nitrates, such as IV nitroglycerin. That completes our discussion of acute coronary syndromes, a few tables to put in our mind, and some critical pathophysiology and pharmacology.